Everyone, welcome back to Healthcare. We're switching gears and we're going to talk about H621, an act relating to health insurance coverage for diagnostic breast imaging. We invited the sponsor of the bill, who's not here at this moment, probably in committee. So we're going to start with Legislative Council to do a walkthrough, and then if the sponsor comes in, we'll make sure we find time. Welcome back, Jen.
Thanks. Thank you. So Jen Kirby, in the Office of Legislative Counsel, we are looking at H621, now on your screen. And this is an act relating to health insurance coverage for diagnostic breast imaging. And so we're looking at another statute in our insurance laws in Title 8. This is an existing law. It's a coverage requirement for mammography. And this would expand that. So we have, under existing law, insurers must provide coverage for screening by mammography for the presence of breast cancer. This would expand that to say that insurers shall provide coverage for screening mammography and for other breast imaging services upon recommendation of a healthcare provider as needed to detect the presence of breast cancer, and this would add, and other abnormalities of the breast or breast tissue. And then under existing law and unchanged here, insurers must provide coverage for screening by ultrasound for a patient for whom the results of a screening mammogram were inconclusive or who has dense breast tissue or both. Under existing law, benefits provided must cover the full cost of the mammography service or ultrasound as applicable without any cost sharing. This would say it must cover the full cost of mammography, ultrasound. I don't know why I did it like this. Mammography, it says mammography, ultrasound, and I think it's supposed to be comma somewhere, and other breast imaging services, and shall not be subject to any co-payment, deductible, co-insurance, or other cost sharing, except we're adding in language, except to the extent that the coverage would disqualify a high deductible health plan from eligibility or a health savings account under federal law. And you've seen this language before. The existing provision saying the section only applies to screening procedures conducted by test facilities accredited by the American College of Radiologists would be expanded to take out that modifier of just screening. And then we have existing definitions of insurer and mammography. This would add a definition of other breast imaging services as including diagnostic mammography, so not just screening, but diagnostic mammography, ultrasound, magnetic resonance imaging, which you may know as MRI, and other imaging services and technologies that enable healthcare providers to detect the presence or absence of breast cancer and other abnormalities affecting the breast or breast tissue. Finally, it would take effect on January 1st, 2025, and apply to plans issued on or after that date when a plan is offered, issued, or renewed, but in no event later than January 1st, 2026. So our kind of standard rollout language for insurance provisions.
Great. Any questions for Jen?
This is near and dear to me. Is there anything in here that identifies what gender we're talking about? This would apply to males as well.
Don't believe it. It doesn't. It just speaks to a patient.
Ensure that.
Yes, and I think, I mean, there are certainly breast cancer in people with all genders.
Jen, what did you say that I missed it when she asked that question?
Oh, there's no language in here that specifies a gender of a patient.
So it can be male or female.
It can be male or female, and I think that was, knowingly done at the time as well, that breast cancer is not exclusive to, or abnormalities of that tissue is not exclusive to any gender.
Any other questions? Leslie?
So we're talking about screening for breast cancer, right? Basically.
Under existing law, we're talking about screening for breast cancer. Under this, we are also talking about diagnostic testing, and we're looking not just for breast cancer, but also other abnormalities of the breast or breast tissue.
So how is it different than what we did for colon cancer, which we tied to the United States Preventive Services Task Force?
I think we'd need to look at what the U.S. Preventive Services Task Force recommends. I don't believe it requires I don't believe under federal law, this level of coverage is required,
Yeah,
which is different from with the.
Okay, so I was just checking that and their recommendations are 2016, and they're in the process of revising them. So I just was curious about tying it to some reliable, and organization that we know does the science.
I think you may want to hear from the sponsor about what she's looking to cover that is not currently covered. I think this is, this is going beyond screening. This is going and into diagnostic work. An earlier iteration of this committee looked at an earlier iteration of this language several years ago. And I think a reasonably different set of coverage than what is currently required. So will be a decision for you all to make.
Would biopsy be included in the language of other imaging services and technologies that enable healthcare providers to detect the presence or absence of breast cancer?
Don't know the answer to that.
I doubt it.
You'd have to hear from, from providers and insurers.
Which we will be hearing from insurers. Okay.
It's talking about imaging. So to me, just to my general knowledge, it does not sound like biopsy, which is more of a mechanical, physical procedure, but.
Thing to ask when we have other people.
Yes.
Great. Thank you, Jen.
Sure.
Representative Sibilia, come join us. Welcome to healthcare.
Quite a break from land use planning.
Very different.
Thank you. Good morning, and Representative Laura Sibilia for the record. Here I have sent testimony to your committee assistant and worked with this bill with Representative Carpenter and the Komen Foundation. Was alerted to this issue by the Komen Foundation. This bill is an act relating to health insurance coverage for diagnostic breast imaging and proposes to require health insurance plans to cover diagnostic breast imaging services without cost sharing. Breast cancer remains a significant health concern affecting countless individuals worldwide, and early detection is paramount. Access to essential screening services such as mammograms and other breast imaging procedures remains a challenge for many individuals due to financial barriers and limited coverage options. And so while the Affordable Care Act has made preventative screening, mammography widely accessible, there are gaps that persist for those requiring follow-up imaging or facing a higher risk of breast cancer. So medically necessary diagnostic follow-up and supplemental imaging are crucial for early detection, but high out-of-pocket costs often deter individuals from seeking timely care, leading to delays in diagnosis and potentially dire consequences. In Vermont, more than 670 individuals will be diagnosed with breast cancer in 2024, and there will be significant disparities persisting in early detection and mortality rates. This bill proposes amendments to Title 8, Section 41A, with the objective of ensuring that insurers provide coverage for screening, mammography, and other breast imaging services recommended by healthcare providers. Specifically, the coverage mandate, insurers would be required to cover the full cost of screening, mammography, ultrasound, and other breast imaging services recommended by healthcare providers for the detection of breast cancer and abnormalities. The coverage shall include screening procedures and without imposing any copayment, deductible, coinsurance, or additional charges except where necessary in eligibility for high deductible health plans. It is inclusive and ensures that coverage extends to screening by ultrasound for individuals who have inconclusive mammogram results or dense breast tissue, acknowledging the importance of supplementary imaging modalities in certain cases. And quality assurance and coverage shall only apply to screening procedures conducted by test facilities accredited by the American College of Radiologists. The proposal would take effect on January 1st, 2025 and apply to all health insurance plans issued, offered, or renewed on or after this date, but no later than January 1st, 2026. So thank you for giving me a moment. It's my understanding that this will bring us in line with a number of other states in the country, and that this is similar legislation and coverage that has been passed in other states.
Great, thank you. Any questions for Laura?
Thank you. Thanks for bringing it
Yeah,
forward.
okay.
I wanted to make sure that the intent of this is to provide full coverage up until diagnosis of breast cancer,
But it doesn't include biopsy.
but not including biopsy.
Yeah, so it won't be diagnosed until it's a biopsy.
Right, she said intent to provide full coverage up until diagnosis.
But you can't, if you don't have a biopsy, you don't have to diagnose it.
Yeah, that was my concern, that it doesn't include biopsies.
You certainly could.
Add it. All right, Art and then Topper.
We know how much it costs for a screening like a,
I do not have that.
We'll have other folks up that can answer the
Okay.
question.
and then what the average copay would be.
Representative, do you know if insurance companies cover biopsies now?
I believe they do. But I do not know.
Okay, we'll find out.
Great, thank you. Appreciate your time.
Okay. Good day.
All right, Emily. Morning.
I did submit some testimony this morning, and I'll walk through it right now. Essentially just outlines, what I'm gonna talk about. But because this was, I felt like a little bit more complex than the colorectal
Yeah.
one, it made sense to put it in writing.
Thank you.
So Emily Brown, Department of Financial Regulation. So we have no position on H621. We're just here to offer, some suggested edits, to help, align it, with current coverage as far as the diagnostic, imaging goes, avoid state required defrayal. And then also what we did is, we looked at some other states. I think Maine was the one that's most recent to kind of compare and contrast with what this bill was. So I think the first recommendation would be similar to what we did in the colorectal cancer screening bill, would be to add in, we don't have it currently, but to add in the screening for screening mammograms, the existing coverage that align with the USPTF task force. So that again is just clarifying language. Insurers are already doing that in Vermont. But that would, again, as Sebastian mentioned yesterday, if something happened at the federal level, bring that down to Vermont and clarify what is actually required for the preventative, the screening mammograms. Moving on to the diagnostic imaging coverage. So the current way that the coverage is laid out is that it says, and this is my second bullet point, it says other breast imaging services upon recommendation of a healthcare provider. And so what we would recommend, and again, this was reflected in the Maine bill and then the Massachusetts bill as well, that it be other medically necessary breast imaging services. And again, this is reflected in the current insurance contract. And what that does is it just ensures that it's not an open-ended benefit really determined by, in all instances, provider. The insurance company still has the ability to say, okay, these are the breast imaging services that we view as medically necessary for the individual. And as I said, this was aligned with Maine. Maine had the medically necessary language as well as the Massachusetts bill. Our second suggested edit would be for when you look at the definition of other breast imaging services, it has this catch-all in other imaging services and technologies. And I would just recommend that the committee just define what those services are. And again, this would be consistent with Maine and Massachusetts, which we looked at. And to the defrayal point too, right? We want to make sure that this is reflecting what currently is covered in the insurance contract. So if you if you make the definition open-ended, it could bring in other services, which then the state would be required to defray as an additional benefit under the Affordable Care Act. And then the last one, I think, this is already in the bill, so you can probably ignore that. It's the carve out for the high deductible health insurance plan. So if there is a high deductible health insurance plan, they're not allowed to offer first dollar coverage of things that aren't preventive. So I think this is already in the bill, but we added another bullet. So happy to take questions.
Questions?
Leslie?
So I have a question about biopsy.
Yes.
So is that included in any of this?
I believe, no, the biopsy issue is not included in any of my comments. I would defer, I'm pretty sure biopsy is covered, but I would like to defer to the insurance company.
No?
Under the preventative task force, do you know if MRIs are part of screening?
I don't know. I don't believe so. But I can pull it. The guidance is publicly available, so I could pull it up really quickly and let you know, but I don't believe it is. Yep. And we're not suggesting that not be included in the definition. We're just saying to make sure that you're not leaving the definition open-ended, which could inadvertently pull in other services that might not already be covered right now.
Okay.
I could just comment on that. As I said, the recommendations are 2016 and they're updated. So that's an I, which is inconclusive, but I suspect it's going to change. So we'll tie it to the most recent.
Right. Yeah.
Which I don't know. It doesn't say when it's going to come out, but it's coming.
All right.
Compared to the bill we just talked about, the colorectal screening.
Yep.
I'm still struggling a little
Yeah.
bit with the difference.
So-
Can you outline for me the difference?
Yes.
If there is one.
So the colorectal cancer screening bill adds in the tie to the USPTF
Correct.
task force, right? And it also changes the current Vermont bill has an age limit
Mhm.
and also specifically identifies, I think, fecal sigmoid. I can't remember the exact language, but what it does is it really just aligns the insurance coverage that's currently out there
Gotcha.
with the federal requirements, right? And then it allows it to be fluidly updated whenever the USPTF updates their
Gotcha.
requirements, right? So let's say they now are like, no, everyone 30 and up needs to have a colorectal cancer screening or and so then that will automatically be activated in Vermont law instead of it being the Vermont law then lagging because it has the age 50 in there. So that's what the colorectal cancer screening bill does. What this bill does, as drafted, is it adds in cost-free care or no cost share care for diagnostic mammographies and other breast imaging services. So it's
Yeah.
essentially adding in a category of services without cost share to our health insurance
That
mandate.
presently isn't covered.
It's covered,
It's covered,
but you
but
have
it
to, you have an
doesn't
out of
have cost.
pocket, or you
Yeah.
have, you have to meet there's whatever the benefit plan is, you
Yeah.
have to pay a cost share to access those services currently. And what this bill would do is make those services
Gotcha.
no cost share.
Thank you.
Yeah.
All right.
So I go to, and this might not be a question for you,
Yeah.
so let me know if it's not. So I go to get my mammogram and it's inconclusive. I think today, potentially depending on your insurance, if you go for the second line of, you would be paying for it.
I think it depends. There is language, I thought, and I can pull up the current language about if it's inconclusive, like due to the density, yeah, and I don't want to misspeak, but I think there
We
is.
did that.
I think that is in there right now.
Right.
So, right, if you have an inconclusive, you can go in and get no cost share coverage for that follow-up, right?
But just for that.
Right, not the diagnostic, not if they're like needing some other service after that, imaging service, that is not considered a screening.
Okay.
And so that would then kind of fall into the diagnostic category, which is what
Which is
is.
what we're doing here.
Correct.
And the changes you're suggesting we make to avoid state deferral, which is
Yes.
great, would not change that intent.
No, it would not change that intent. It's more just, again, making it in line with what we want to make sure when we were looking at this, we want to say, okay, what is currently being covered, right? Not aside from the cost share piece, what's currently being covered in the insurance market in Vermont? We're really concerned about the essential health benefit plan, right? Because that's the plan that then triggers the defrayal at the state level. So what this does is it says, okay, we want to make sure that the definition of the diagnostic imaging is matching what's currently being covered by our QHP market. And that way you don't inadvertently add in extra services that then the insurers come to us and say, we weren't covering this, state of Vermont, you're going to have to now pay for those services for these folks.
So to piggyback on what you just said, so if it's inconclusive and the recommendation is an MRI because of density, would that also fall under that? Because I think that is something that is being recommended, but may not be. I think ultrasound and MRI may be being treated differently, even if they're both recommended.
Yeah.
They're inconclusive. So I'm just curious as to where that.
I don't know, and I'd like to defer to the insurers who are here to testify. I'm not as familiar with like the claim level, how that's handled and coded. So maybe, there are other providers are here too, so they can probably speak to that. Yeah.
Great. Any other questions for Emily? Great.
Okay, thank you.
All right, Alex.
Hi, good morning, everyone. Can you hear me all right?
We can. Good morning. Welcome to healthcare again.
Always a pleasure to be here with you. Thank you, Madam Chair. Thank you to the committee.
Alex, you just got really garbled.
Okay.
Might be better off without the video.
Yeah, I think it's not going to like my video today. I apologize. Am I coming through all right now?
No.
Sorry, I'm trying to adjust my connection.
You're fine now.
Okay, perfect. I will go with it. I will also be very brief today, so I'm happy to get.
Actually, whatever you just did, now you're not.
Okay, give me just one moment. I'll try to rejoin the call.
Okay.
Get closer to the big line.
Yeah. We'll give him a minute and then we can switch to the Chrysler Shield if he's.
Okay, I do apologize for that. Am I coming through any better now?
You are great.
Okay, perfect. Thank you so much, Madam Chair, members of the committee. Thank you for having me this morning. For the record, my name is Alex McCracken. I'm the Director of Communications and Legislative Affairs for the Department of Vermont Health Access. I will be very brief this morning, and this might feel a little bit like deja vu from my testimony yesterday. DVHA is very supportive of the content of this bill and the intent behind it. We certainly support increasing access to diagnostic imaging services wherever possible for our members. Our only concern here on this bill is the effective date on the last page. We would ask that the effective date be moved to 2026 as plan design for qualified health plans has already been completed for 2025 at this point. That is really the only note I have to flag on this bill from DVHA's perspective. And I'd be happy to answer any questions that I can at this point. And of course, we're always available as a resource for discussion.
Great. And so I want to be clear. that you're talking specifically to qualified health plans and not Medicaid, right? Because this does not address anything with Medicaid coverage.
That is correct. Yes.
Okay. Any questions for,
Well, my question maybe is for either Alex or you, Lori. So Medicaid coverage covers us anyway.
we don't know. Alex, what does Medicaid coverage cover for this?
I would need to get a specific answer for you on that. I believe that what we cover is in line with what's in this bill.
Okay, if you can get back to us, that would be great.
Yep, can do.
Great. Well, that was easy. Any other questions for Alex? The healthcare advocate might have a question.
Hello, Alex. Mike Fisher, healthcare advocate. I wonder if DIVA could provide the data about how many people are in high deductible health plans versus non-high deductible health plans in the qualified health plan marketplace.
We can work on providing that data. Absolutely.
Right. Because the question is, how many people will this actually impact? That's a really good question. Thank you for asking that. Yes,
Thank you,
Alex,
Mike.
that would be helpful.
Of course. I'll take that back to the team and we'll get what we can for you on that.
Okay, thank you. Great. Appreciate your time.
Thank you so much.
Sarah?
Thank you. Sarah Teachout with Blue Cross and Blue Shield of Vermont. A couple of things. So first, we would prefer the language that the Department of Financial Regulation suggested about adding medically necessary. And other than that, just to let you know, in addition to mammograms and ultrasound, we also cover MRI and PET scans if the doctor recommends those.
Okay.
And then the issue of creating the cost share, two things. One, we agree with DIVA that the effective date would not work because that's not how we are implementing this currently. So there's zero cost share now for preventive breast screening, but not zero cost share if it's diagnostic. So the issues that we see with eliminating the cost share for diagnostic breast screening are we can either increase premiums to change the difference, or we have to raise the costs on other services for which cost share is allowed. The issues that we're finding are really with the bronze plans the most, because the Affordable Care Act requires that 40% on average of everyone who has a bronze plan has to pay out of pocket for about 40% of their healthcare coverage. And we have a lot of mandates currently in Vermont requiring no cost share for certain things. You know, like the recent one for contraceptive coverage has turned out to be substantial, as well as the cap on, the other big one we find is the cap on prescription drugs. So Vermont's one of the only states that has a separate cap for prescription drugs than for all medical care combined. So those sort of restrictions make it difficult for the people making, designing the plans, and the actuaries trying to hit the actuarial targets to work it all in. So those are the issues faced when you make those changes. So I think those were the 3 points I wanted to make: adding medically necessary, the difficulties with with adding diagnostic, and then the effective date. I did hear some questions that I can try and proactively answer, but I don't know if I can answer them all. One is, are biopsies included? Yes, they are part of regular healthcare coverage. I'm not sure. I don't think they're considered preventive care. So there would be cost share on those.
There would be cost share on this. Okay. Melanie?
Is an MRI ever considered preventative if the other diagnosis or the other screening techniques don't work?
It could be, yes.
So if someone has a dense breast and they need an MRI, they could get that under preventative?
I'm not going to say in all cases, because I think a lot of it depends on how it's coded. You know, we're not going through every claim that comes in and making a determination. Our systems say coded as preventive, coded as diagnostic. That's how the benefit is applied.
And so in this case, if we change it to include it for the diagnostic, it would be covered at no cost share
For
if we
all.
move forward with this. Okay. All right.
Is it possible to get a dollar figure on how much this is going to cost. I assume you have to go past.
Yeah.
And see, I would be interested in seeing what the hit, the other ratepayers.
Sure, I can ask that. And then I also heard you ask how much these services cost. And again, for commercial health insurance, there's going to be a range, per screen. So I can
There's
look
something
at the
to,
range.
and the other thing I'd like to see is what services have we recently, at least last couple, 3 years, have we done this for? What have we said that we want to do without a fee?
Okay, I guess I'd have to ask how far you want to go back because.
Yeah. I'd just like to know.
Hearing aids?
There's cost share for hearing aids.
Yeah.
I think, I'm trying to think, there've been proposals every year. Yeah.
I mean, there's been a lot of legislation since,
Right, I know.
so I just
Yeah.
don't have it off the top of my head.
Yeah.
I also don't remember everyone we discussed versus everyone that's.
That we put in. Exactly. Yeah, I would say for the state deferral, most of them we probably haven't passed.
So I thought you were talking about no cost share versus defray.
Yes.
Kind of two different issues.
Two different things, yeah.
Okay.
Leslie?
So I'm wondering if your actuaries can estimate how much is saved by early detection of breast cancer, which would then avoid ongoing treatment, et cetera, et cetera. Because I know you talk about premiums in the moment, but having a longer vision, is there a way to estimate that savings?
Right. So I don't think our actuaries can estimate that. I mean, clearly we all know that, and I'm sure there's plenty of studies that say that early detection results in, better outcomes. We're always looking at the health plan year and the cost of premiums in 1 year. So it's not, there's certainly.
Wouldn't it be, or if I could ask, to your advantage in some ways to look beyond the plan year? Because you're going to be paying for chemotherapy or not. I'm just thinking about that.
I think the same question could be asked of us and how we do our budgeting in the state house. I think both could have more long-term.
I wish we did.
Visions. Yes. So Sarah, this would apply to just QHPs, correct?
QHPs and fully insured large group.
Fully insured large group. Okay.
And not anyone with a high deductible health plan.
Right.
So I heard the question, I haven't looked recently. I think it was at least 2 years ago that I asked how many Blue Cross members have high deductible health plans. And it was about 40%.
Okay.
But I don't know the latest, and DIVA would have estimates for the full population, not just Blue Cross.
Okay.
Theirs is a better number.
Okay. And so, there is a question, I think, on the table on not about what this potentially could mean for premiums. Is that asked?
Yes.
Okay, great.
So again, it may or may not increase premiums if we have to shift it to other costs. So that's the question I don't think I can answer right now. And, the Healthcare Advocates Office participates in these plan design meetings too. There's a range. So say the bronze plan is supposed to be 60% and it's plus or minus 2. If it falls in the range, we don't make those adjustments because that's pretty complicated. But it's when you're pushing it outside the range that then we have to go through and adjust the out-of-pocket costs for other conditions. So I guess, the one thing I would say is that our actuaries and people who work on the benefit designs try not to preference one medical condition over others. They try and treat them all the same.
Any other questions for Sarah? Great, thank you. Bill?
Thanks for having me again today. Jill Sudhoff-Karen. I'm representing the Vermont Medical Society. And I just want to express our strong support for including diagnostic programs within the zero cost preventive breast care screening. We all know that regular and comprehensive cancer screenings are going to provide early detection and less cancer incidence, better cancer outcomes, less costs for the whole system, and ultimately save lives. And so we also feel like by providing the diagnostic imaging, you're going to provide clarity and assurance to Vermont patients that right now sometimes forego care when they get those callback mammograms. So I'll also just say what, right now, health insurance plans mostly cover a mammogram every year after the age of 40, but that has changed recently. And these screening guidelines that kind of go all over the place are confusing. Different insurance plans follow different screening guidelines. And then I also have seen that some healthcare facilities follow different screening guidelines, and all that just adds for the patient this concern around cost. In my testimony, I included this graphic. So I don't know if anybody knows, but before I worked for the Medical Society, I worked for the Cancer Society. And in 2013, we worked on a bill to get callbacks included in the screening. And so it is defined in our statute that additional views should be covered within the screening, but the coding around that is not always clear. And it looks like about 10 to 12% of mammograms require these callbacks. And I even saw yesterday that on a certain healthcare facility site, it said these are deemed as diagnostic. Now, we went to DFR and we got them to put out a bulletin that said, this is the modifier that you can apply and that callbacks should be deemed as screening. But there are so many people that pay for diagnostic for these callbacks, and callbacks are not always, even showing any abnormalities. A lot of you probably have had them, but it can just be for a fuzzy image. It can be just that they need another view. And so we feel like this diagnostic imaging being included will actually make people follow through and get that callback. Because what I got all the time, and I'd love for you to look at the graphic that I put in my testimony, is that people were not going to go, that they were scared to go, that they didn't know how much it was going to cost, and that they couldn't afford it. So we feel like that this would be an important step to get people to follow through on that. I did include the bulletin as well. We know that breast cancer is the leading cancer among Vermont women right now. And then that was in the 2022 data, the cancer data pages for Vermont. And it shows there that breast cancer screening rates are in trend with a national average. But I don't know if anybody remembers, but last year UVM published a study from April 2023 that actually showed a major decline in Vermont. We were the second largest state in declines in screening rates among our most highest risk of women in the ages between 50 and 74. And the study, which I did include in my testimony as well, it attributes it to the kind of ping-ponging of these screening guidelines, because in 2009, USPSTF went up to age 50, and then now they're back down to 40. And so you have people really wondering, and having this disparity about, well, if it can range this much, do we really need to get it? And then, of course, you have concerns about costs. And I'll just say that this was 10,000 fewer women that got their screenings in that age. So it was very significant. So we feel like it's time for clarity and comprehensive coverage. And we ask you to support the diagnostic mammograms.
Can you give me some sense of what an average copay, deductible, everything would be for a woman who has a screening?
Yeah, so the range, I believe, is between like $250 to $950 within that range.
Okay,
But when I worked with the Cancer Society, there were some women that were going that didn't have insurance coverage too, that were paying higher out of pockets. So there, yeah, there was definitely I got a lot of calls from people saying, I'm really concerned about this callback. And I actually reached out to UVM because we were trying to get a radiologist. I'm just gonna pull up because I did get an email from Hannah Perry today. And she was just talking about their experience, because I was asking her if she's still seeing people forego care for the callbacks. And she said, we do see patients not coming for diagnostic imaging due to concerns over cost. One scenario that seems to come up fairly frequently earlier this week, in fact, is when patients need diagnostic imaging but have high deductible insurance plans. So actually that wouldn't help us here. And cannot afford the costs associated with a diagnostic workup. So they make the decision to decline the next evaluation. So that won't help us here, but
why
yeah.
won't that happen?
So if you
here?
have so we have language in here, it's standard language. If you have a high deductible health plan, then this won't apply to you. So you have to use that.
Okay,
Right.
it won't apply to you, meaning,
Jen, do you want to describe it?
Sure, Jen Kirby Lynch.
sorry.
No, that's okay. So the language that we put in, because the federal government defines which services are considered preventive for purposes of first, what's allowed to have first dollar coverage, so no cost sharing. For a high deductible health plan, in order for the plan, that high deductible health plan to be eligible to be paired with a health savings account. And so, which is what people typically use or often use with a high deductible plan, have a health savings account where they can have.
They pay that, okay,
Right. And so,
okay,
in order to not lose the eligibility for a health savings account for those high deductible plans, Vermont cannot apply
Gotcha.
first dollar coverage provisions to anything that the federal government doesn't allow to be considered preventive.
gotcha. All right, I
It's
think I got it, that's good, I understand. Thank you.
So, could I ask, the Blue Cross Blue Shield representative, do you pay for the callback? Do you cover that?
Yes,
You
we
do?
cover it all. It may or may not have cost.
Sharing, right?
Yeah,
Right, so the out-of-pocket expense may or may not be covered.
all covered.
So this was also a coding issue, and Alyssa and I were talking about this a little bit yesterday. So we spent a lot of time, and that's why the DFR bulletin went out. We were trying to really get across that in our state statute, if you coded it correctly, then the callbacks would be covered. But it's tied to national coding, and so some facilities don't know that, and so oftentimes it's just coded as diagnostic.
So we have an education program, so to speak. We
We
do.
need to. We should.
I have another, I'm sorry.
I'm sorry, did you have your hand up?
Yeah, or.
Oh, I forgot.
Went to stop.
I
What did I do?
look to my right more than my
I know.
left. Go ahead, and then we'll go back to Art.
I think I'm gonna ask this question of you, and you may not be able to answer, but I'm gonna ask it of the next two witnesses as well. So I actually have a lot of faith in the US Preventative Task Force.
You do or you don't?
I do.
Okay.
I actually do. So their recommendation is not to do this because they found no evidence. And also the risk of harm. You know, I mean, when you do more procedures, you're actually increasing the risk of unnecessary procedures oftentimes that can pose a risk. So what is the research on whether or not ordering continual levels, is there actually evidence that it diagnosis?
I
Is there a
understand the
benefit?
question. I'm not knowledgeable enough to answer it. I mean, I've looked at the same information that you have around the risks of overdiagnoses and overcare, because that's the concern, right? But I will just say, for me, knowing that how many people reached out to me and still do, because my phone number is still on this, and still call and say, I don't want to go unless I know it's going to be covered. And so we're talking about 10 to 12% of the mammograms. That is not insignificant. And so I feel like this would help with that. I don't know how to respond, because I feel like I do trust our healthcare professionals not to overdo. That is, I trust them.
Well, and I think if you get a callback, it's gonna be up to the patient to determine if they want to go forward or not. And this would give them the opportunity to go forward if they can't afford the cost share.
I'm just wondering, is there a benefit to clinically to the callback?
Well, I don't think that's the question on the table, because that's what's happening today. So the question is, if there is a callback, are we gonna allow cost share?
Yeah, and if we say no cost share for the callback, will we have more callbacks? And is there a risk to more callbacks?
I don't know. I guess I would just fall back to the College of Radiology has a set of principles that they follow. Every, clinician has a set of guidelines that they follow. This won't change that. This is about paying for that screening.
Art, and then Leslie?
Yeah, just quickly, what happens when you get to Medicare? Is it different, as far as payment?
Oh, when you're on Medicare?
Yeah,
Yes.
and we don't affect that, I don't know.
No, we don't.
We have nothing to do with
No,
it.
nothing to do.
But I wonder what does happen, do we know?
I
Look at the age of everybody.
Melissa seems to know.
Leslie may know. I don't know.
Pull it up for you in about 2 seconds.
They pay 80% of it.
Leslie, why don't you go while she?
Well, I know she's reading, I think she makes a good point about overdiagnosis, and that's a concern. But I'm not sure that we're in a position to be managing overdiagnosis in this setting, that it has to come elsewhere, like from the prescribers, the orderers and
Yeah.
be aware.
Yeah.
So I think there's a distinction.
Yes, I do too. Thank you.
And for people that get an inclusive, a non-inclusive, inclusive. Inconclusive, thank you, mammogram, and they get called back and they choose not to have that because they can't afford it. I feel like that's a problem that takes away an opportunity for early detection. So that's what I feel like this bill is looking at.
Yeah, that's the gap that we're trying to fill, not how people are managing.
Exactly.
All right, questions for Jill? We'll come back to you. Great, thank you, Jill. Right, Lola, you want to come up?
Thanks for the word help.
You're welcome. And remember that comment. Question.
Sure.
Welcome, Mike, if you can introduce yourself for the record.
Thank you. For the record, I'm Mike Rolo, the Government Relations Director for the American Cancer Society Cancer Action Network. I've never been so happy to follow my former colleague than I am today. And I'm also happy to follow, I don't need to be repetitive because quite a bit of what I wanted to say has actually been said by several other people. So I'm going to skip down in my testimony, if that's all right, Madam Chair. But for the record, I want to say just thank you for the opportunity to provide testimony on this. Just for you all, maybe you don't understand or you don't know, but the American Cancer Society Cancer Action Network, or ACS-CAN, which is a mouthful, I know, is the nonprofit, nonpartisan advocacy affiliate of the American Cancer Society. And we advocate for evidence-based public policies to reduce the cancer burden for everyone. And on behalf of our constituents across the state who have been personally affected by cancer, we urge your support of this bill. Now I'm going to skip down to the parts that haven't been covered yet. As has been stated already, though, that approximately 670 women in this state will be diagnosed with breast cancer in 2024. But what hasn't been mentioned is that approximately 80 women will die from the disease this year alone. And that costs are a known barrier to healthcare generally and cancer screening specifically. And the elimination of cost sharing is associated with increased cancer screening. Cost is also a barrier to completion of follow-up tests that are recommended after a normal cancer screening. Unexpected and unaffordable costs may cause individuals to delay, or forego additional imaging tests to rule out or confirm a breast cancer diagnosis. And delayed follow-up is associated with later stage disease at diagnosis, which I think is really important to stop and think about that again for a moment. Delayed follow-up is associated with later stage disease at diagnosis. The question was asked by you, Representative, is it beneficial to the carriers to find at an earlier stage than to treat with a whole host of treatment, whether it's chemotherapy or whatever, radiation? And obviously the answer is yes. I mean, it is. But it's also much more beneficial for the individual. They have a much better chance, better outcome to find this at an earlier stage than at a later stage. And that's what we're hoping for, what we would want to see. The implementation of no-cost preventative services under the federal health law have paved the way for more people to get regular, age-appropriate cancer screenings. However, cost barriers to completing the continuum of cancer screenings are undermining the desired outcome of determining whether the patient has cancer or not. And without resolution following an abnormal cancer test, the promise of cancer screening cannot be realized. And given the evidence of the patient cost sharing, whatever the source, diminishing the timely uptake of essential cancer care associated with the full continuum of cancer screening, ACS-CAM supports this legislation to eliminate the cost sharing associated with recommended cancer screenings, including the supplemental and follow-up testing through diagnostic cancer care. And we would urge your support of H620. I did want to address quickly, I have the advantage of working, thank you, COVID, I guess, of working in both the state of Vermont and the state of New Hampshire. I started my career with ACS and ACS-CAN 13 years ago as the government relations director in New Hampshire. And we're working on the same bill on both sides of the Connecticut Road. In fact, this morning, the House Commerce Committee in the New Hampshire House was going to exec the bill out of committee. They've delayed it because they need to revise the effective date. There was an error on it. But they've been working on this bill for 2 months now. We've had several subcommittees. The subcommittee recommended 5-0 that the bill ought to pass, which is no small task, because I don't know if you heard or not, but they don't really like mandates in the state of New Hampshire. Live free or die.
Free and die.
Yeah, fair enough. But I'll take that. I'll take that. However, that being said, the New Hampshire Department of Insurance found there were no defrayal costs at all. They had a revised fiscal note. They found that it's an extension of an existing benefit, that there should be no defrayal to the state of New Hampshire, and that there should be minimal to no cost to ratepayers, that there should be no increase to premiums in the state of New Hampshire. That is, now we do not have the same exact insurance markets, I will give you that. But I think it's important to note that the Department of Insurance found that there would be no increase in premiums, and that they do not take positions on legislation ever, but they found no reason not to pass the legislation, which was huge for them to say that. I just wanted to say one other thing, and now I'm drawing a blank. Oh, you had a question, Representative. You were going to ask me. And if you don't want to ask a question, it's okay, I won't fight it. But I think if I was remembering correctly, because I remember this issue coming up, not in New Hampshire, but in general, about the U.S. Preventative Task Force wanting to avoid over-treatment for cancers that may not progress beyond advanced stage, early stages into advanced stages, and that we may be over treating certain things. I thought was what the Preventative Task Force was saying, not necessarily, which would be not necessarily associated with this legislation. I may be misremembering, but I can tell you my organization does not endorse legislation willy-nilly. We are very conservative in the way we approach our endorsement of legislation. It's all based in sound science. We are very, very careful in how we approach our endorsement. We will not sign on our name to any legislation unless after careful consideration. So we would not have joined a coalition of support for this particular bill if it were not in the best interest of cancer patients. So that would be the answer I would give to your question.
Great. Any other questions for Mike? Art?
In New Hampshire, did they come up with dollar figures that this would save past or future illness? Did they figure that out, or was it just somebody said premiums will increase, the deductibles?
They did not, Representative. The question was asked whether or not they wanted to delay a full year to do the next level of study.
Yeah.
Which after the initial review, when they found there would be no increase to premiums, they just the subcommittee of the House and Commons Committee on Insurance said no, there was no need to do the full review. They said they didn't need to look at what the cost savings would be. They were more interested to see if it was going to increase costs.
Yeah, right.
So they did not go to that next step.
Oh,
so I can't tell you. So they didn't do it.
Do you guys keep stats? Who dies of what by cancer?
Unfortunately, yes.
Yeah.
And I didn't mention that. Thank you for the reminder. Good, now this turned off. So I did email yesterday my testimony, a fact sheet, the revised fiscal note from New Hampshire, in case you want to see it, but also the cancer facts and figures that we put out every year for the entire country, but it has Vermont specific figures, and it will give you specific cancers for all sites, for all sites, I mean for your state. And we track only female breast, unfortunately. We do not but it is important to note, and thank you for bringing it up, because people always just assume that it's only women that get breast cancer, but it's not true. It happens for everyone. So, but we track only female breast, colon, rectum cancer, leukemia, lung and bronchus, melanoma, non-Hodgkin lymphoma, prostate, urinary bladder, uterine cervix, and uterine corpus cancers by site. And so you have all that information. That's for this year alone. And there's a whole host of other information for your committee, and that has been emailed to you. So you'll have that.
If you don't.
Yesterday.
Thinking yesterday.
Did I go to yesterday?
We'll get it to you.
Oh, it's not yet. Okay, got it. So I just
It was emailed directly to you, but I mean, I don't know if
know.
Post it too.
Yeah, a lot of people might have. I'm sorry.
Go ahead.
I do it wrong, I'm sorry.
No, there's nothing wrong with it. No, but it had a warning that said message encrypted.
Oh.
And maybe something.
I do something, I might have done something wrong, I'm sorry.
Yeah.
Sorry.
I just wonder if that's something.
It is posted.
Okay.
Great.
If I screwed something up, I apologize.
Some people might not have opened it because they might have been afraid when they saw that.
I would have been, right. Sorry about that.
All right. Any other questions for Mike? I want to make sure we get everyone in. Any other questions?
Appreciate your
All
time.
right,
Thank you very much.
Thank you.
Welcome.
Thank you. Last but not least. Hello, everyone. I know I'm a new face here, so it's very nice to meet you all. Nice to meet you. So I thank you, Chair and members of the committee. My name is Angelica Katz, and I'm the Regional Manager for Susan G. Komen. Komen is the world's leading nonprofit breast cancer organization, representing millions of people who have been diagnosed with breast cancer. We advocate here today on behalf of the estimated 670 individuals that Mike mentioned who will be diagnosed with breast cancer this year, and unfortunately, the 80 who will pass away from this disease in Vermont. So I know it's been already mentioned, but I just want to reiterate, under the Affordable Care Act, screening mammographies are covered. This is diagnostic. So about 16%, I think back in 2013, it was 12%, but now it's about 16% of women or individuals, we like to say patients, will need to get a follow-up imaging. Now, this is really critical in potentially diagnosing breast cancer. This does not cover biopsy. That would be the next step. That's the diagnosis. But we've seen, and what our Komen Commission study, which I can share with committee members, that a primary cause of women or individuals foregoing their test is because of this cost sharing. So I'd like to share a story with you from a patient who came to us after she refused the diagnostic test because of an $80 copay. She said $80 could have been $8,000. She was a single mother trying to make ends meet until one day her cat had jumped on her chest and she was in so much pain that she took out a payday loan, which ended up being more costly than the initial $80. She needed to get a diagnostic test. She was diagnosed with breast cancer shortly after, and because of her later stage diagnosis, she had to receive chemo and radiation as well as surgery to remove both her breasts due to the late stage diagnosis. And if she was able to afford to be diagnosed earlier, then she may not have needed the surgery or have lost her breast, and her treatment overall would have been less costly. We know that breast cancer can be up to 5 times more expensive to treat when it has spread beyond the breast to other parts of the body. I can share a study with you as well on that. So simply put, this is a cost savings bill, not only for the patients, but overall the New Hampshire healthcare system. And also to answer your question earlier too about what the cost is usually, we've found nationally it averages around $234 to about $1,100 for a diagnostic. And that could be an ultrasound and MRI. And yeah, and also, like stories like the ones I have, just like the one I just mentioned, really is not that uncommon. And also I want to mention too that this bill will cover breast cancer survivors. If you need to go in for a routine follow-up imaging to make sure that the cancer has not come back, this will also be necessary for those individuals as well. We know Vermont is a very rural state. We want to try to remove one less barrier if we can. And I also want to mention too that this similar legislation has passed in 20 other states. And states like Connecticut, Arkansas, Colorado, Delaware, Georgia, Illinois, Louisiana, Maryland, Texas, this is a bipartisan issue. This is not, if all these states are getting on board, this is not, a one-sided issue. We've also seen in Massachusetts, which also has pending legislation, and they did a study there that they found that a typical members' monthly health insurance premium under this legislation would raise about 19 cents to 33 cents per month, which at the end of the year is about a medium, cup of coffee from Dunkin' Donuts. It's a pretty small price to pay to save. And with that, I think that's all I have for you all. And I also wanted to bring up too, since the U.S. Preventative Task Force question came up. So because I'm speaking last, I was able to look it up. So the U.S. Preventative Task Force makes recommendations for preventative services for average risk women only. So this bill would, for diagnostic services, or for those at higher risk, which is recommended by guidelines, is what, sorry, I got a little bit tongue tied. This bill will serve those who, who who are at higher risk. So, just this falls in line with medical guidelines. So I don't want you to think that we're somehow going outside of that. And I can also send you more information on that as well. And yeah, and if anyone has any other questions, I'm happy to answer them as well.
Great, thank you. Does anyone have questions?
And excuse my ignorance, and I'm trying to understand what this covers. And all the women in the room have probably been through this numerous times. When you say, or the bill says other breast imaging services, is that diagnostic? Is that what that is?
Well, first you need the mammography. So if you're 40 years of age or if you're at higher risk, you'll get a mammography, and that's a preventative screening. But if there's an abnormality seen on the mammography, then you'll need a follow-up test.
Okay, I'm writing because I want to
Yeah.
ask a follow-up. The
In
screening,
the follow-up test is considered diagnostic.
okay,
And does not, although it's covered by, depending on your insurance, there is probably cost
okay,
share.
right, I get that part. But the screening, you said, was covered by the Affordable Care Act. So if you go in for a yearly screening, that's covered.
Right, correct.
Okay, so this is beyond that.
Yeah, this is for the, I don't know how many percent of women or individuals get a call and say,
Your screen showed something.
show something, or it was fuzzy, or we need to do something.
Gotcha. Okay, see, I didn't understand.
Yes.
Okay, I see now
Sorry,
what
we
we're
should've-
talking.
we
Well, I
should've-
just don't know.
Step back for a moment. Does that help?
Yeah, oh, that's everything.
Okay.
I want to make a comment. Mammograms are not preventive. Mammograms are early detection. And I think it's important to understand that because the early detection is what leads to saving lives. We're not preventing anything.
You're correct. Good comment on the words we're using.
Yeah.
Language is important. Any other questions? Thank you so much. We appreciate it. So, Mari.
Yeah, I just wanted to add to the conversation about the imaging and follow-up imaging, of the three potential imaging that we're talking about, whether it is a preventative screening or whatever you said, Leslie.
Early detection.
Early detection screening versus diagnostic. The mammogram is actually provides, it is higher risk than ultrasound or MRI. Ultrasound and MRI don't use ionizing radiation, mammograms do. So as far as harmful procedures moving along the usual steps towards, okay, you have a dense breast, the radiologist can't make a determination on that, on the mammography, which is X-ray, is ionizing radiation. That's where the risk comes in, and it's still small in the scheme of things, but it is a risk, and there is evidence to show that it can increase the risk of breast cancer, mammograms themselves, but ultrasounds and MRIs, no.
Thank you for that clarification. I have a question for Blue Cross and DFR. And it probably isn't something you can answer now. And I know the numbers are probably different, but I'm looking back to what we passed in 2018, Act 141, which was the dense breast, where we allowed, I believe, tell me if I'm wrong. So it says, in addition, insurers shall provide coverage for screening by ultrasound for a patient for whom the results of a screening mammogram were inconclusive or who has dense breast tissue or both. Wondering if we have any data on the cost to premiums and or the numbers that, okay, since we don't have a number in front of us, I'm trying to get to like, what happened with that bill?
Yeah. I think the question too with that is, was that already being covered as well, right? Like, so the ACA was enacted in 2013. I think you said that was 2018.
2018, yeah.
So was that like an issue that came up, but it was actually already required to be covered and therefore didn't have an impact on rates? Or was that, because again, if that was in addition to what the preventive services would be, that would be a deferral thing.
Right, which I don't
I don't
remember.
think we did that.
I don't think we did
Yeah,
that
I don't
either.
think we did that. So that's the question that comes to my mind. And we don't, DFR doesn't have any data on that, but
Okay.
I'm sure, I don't.
Because it's still, I get your point, but it's still, if it wasn't, it would still say no cost share, right?
Yes.
So that's the
exactly.
piece that,
Yeah.
so Sarah, I don't know if you
I
have.
don't have an answer right now.
That's what I figured. Okay, no, that's okay. Leslie,
This is really quick. Emily, you have two names on our website. Are you?
so it's a different Emily that sent in the testimony. It's under.
Oh, Emily Kosicki.
Yeah.
Yeah, she's our.
Oh, that's a different
Emily
Emily. Yeah.
B, that's.
I got really
okay.
confused. I thought you got married or something.
No. Well, you know,
I was gonna go back. Let me congratulate you.
What happened in a week?
Sign up for your testimony.
All right, so I think at this point, what we should do is think about this. We'll see if Blue Cross Blue Shield can come back with any type of estimate in the next, day. And then we'll try and find some time, maybe tomorrow, to do a committee discussion like we did this morning on the colonoscopy one and decide what to do before Friday. That seem right?
Could I have a minute or two?
You,
If you have a minute.
absolutely, come on up. And, yeah. Yeah, go ahead.
Oh, can I ask a question of Sarah, Blue Cross Blue Shield? I'm wondering, so, in follow-up, particularly with MRI, if it's, they see something and they are like, let's do an MRI, is prior approval required for that through Blue Cross Blue Shield? That's a question that, yeah.
Good afternoon, good morning still, Mike Fisher, healthcare advocate. I guess I just wanted to give one other scenario that I have not heard come up about the reason why this bill is a good bill. And just to say, both prior to being the healthcare advocate as a legislator, I was involved in this issue. We thought we fixed it. When I was a member, and clearly sort of the language of screening versus diagnostic has a different meaning to lay people than it does to radiologists. And so it took quite a bit more work. And if you've ever been in a work group with radiologists and coders, different world.
Jokes about
A fabulous world, I'm sure.
Fabulous world.
We thank them for their work. Thank you for your work.
But in 2018, when the bill was going through and there was an effort to extend it to diagnostic unsuccessfully at that time, there was another scenario that was talked a lot about by radiologists. That is, if a person comes in and says, I have a concern, got a lump, I've got a discharge, I've got a pain, I've got something going on, it's no longer screening. And so that's the dynamic where we want to say, we want you to come in. We don't want you to say, this copay and deductible. By the way, I can tell you we can give you those numbers, how much copays and deductibles and out-of-pocket maximums are in the marketplace. We don't want someone to have have a financial barrier to coming in and getting screened or getting a diagnostic image to get treatment. So
that would change, this would change that.
this would change that.
That's really important. I'm so glad you brought that up.
Segment of the population who are not in high deductible health plans. And, and from the radiologist perspective, they say, we want to know if a patient has a concern and we're doing imaging, we got to do the right imaging. And to say to a patient, you can't tell us what's going on for fear of financial consequence is bad for treatment.
Right.
And so I would just want to put that one additional.
Yeah, and I just want to make sure everyone understands this. I'm looking at Art before you ask the question. Okay, so I go in for a mammogram. I call my doctor, right, for my annual exam, or they call me usually and say it's time for your annual exam, annual mammogram. And they'll ask the question, do you have pain? Do you feel a lump? Do you have discharge? If you answer that yes to that mammogram is no longer covered without cost.
Gotcha.
And so people.
Becomes diagnostic.
Right, and so, and I remember when we did this in 2018, that was a big concern. And so that, thank you for bringing that up, Maureen.
And to your point about how important it is for the radiologist, it's literally when when the radiologist interprets or reads the image, whatever it is, the thing that the provider has to provide when ordering that imaging is the reason for the X-ray, and it has the information about discharge, whatever the patient's complaint for. So it is critical for accurate interpretation.
Thank you.
Again, the cohort we're talking here, what are we talking in this, with this bill?
Qualified health plans, so our normal group. Only if
Small
they don't,
market, group market.
and then only if they don't have a high deductible plan, which is.
So it's a pretty small group.
It's a pretty small group, and we're hoping to get some numbers from Alex. Yes.
Okay. So, all right.
Unfortunately.
Got it.
Unfortunately. Great, thank you. Okay, we are back here at 1:15. We can go off. Yeah, thank you.